Hello, Insta fam. It's Dr. T here, randomly hopping on, not even giving you guys any notice. I have been decidedly absent for a while. A few people have noticed. A few people have been saying, hey, where are you? Just having some time out, actually. I have completed my 6 chemo sessions. And it's been a bit rough. The last couple of cycles were quite rough. Thank you very much. Good to be back. And just have not felt the vibe. Haven't felt the vibe to hop on, so apologies for being so absent. I have pretty much lost all my hair. It's pretty much all gone. So it's cold and I wear a beanie. I must say, if anyone out there is good at making headwear, I really haven't come across any really nice turbans. I bought one yesterday at the Cancer Council, and it's a yoga turban. I don't love it, I've got to tell you. So if anyone's looking for a business idea, making really great turbans. What else? So I'm just over a week post my last chemo, and I thought I'd be celebrating. I thought I'd be like, yeah, rah, it's done. But I did sit with my oncologist on my last chemo day, and we talked about the what next, and the what next is surgery. And he kind of said, well, what happens after that depends on whether we have complete treatment of disease, so no presence of invasive disease. I have invasive ductal carcinoma. Or if it shows some evidence of invasive disease and therefore it's been incomplete treatment. So again, I come to this crossroads, right? And it was a little bit of a shock because I had kind of thought, right, the big bad stuff is kind of done. Because if it's incomplete, then I score some other treatment that's kind of like chemo that has similar side effects like peripheral neuropathy, which this cycle is actually, my fingers have been a little bit sensitive and numb, as have my feet. So it was just that moment of, oh, I'm not finished this yet. And I guess I was a little bit taken aback. I knew I had surgery to come, and I knew that there was the possibility of radiation. I probably hadn't really wrapped my head around the fact that I still have 11 cycles of Herceptin to go, and then the possibility of adding in this chemotherapy to that as well, which really takes it through until February of next year. And it was just demoralizing. In a moment, it was really, really demoralizing. And then I was just yesterday reminded by my very dear colleague, Dr. Jess Clifford, shout out to Dr. Jess, that it's really important in this 1 year long journey to chunk it down. That you got to celebrate the small wins, but know that this journey is just made up of chunks of time. And I suppose that is the same in IVF as well, that you've got to celebrate the small wins. I know that you guys want the live birth, so do I. We are on the same objective. But sometimes in this journey, which is sometimes long and often hard, it's really important to chunk it down. So chunk it down to, yep, that first cycle is done. I've mastered the art of giving myself injections. I understand the blood tests and tracking regimes. I get, done. Good. I have mastered the egg collection. I've done my first egg collection. Fantastic. I have managed to get to a transfer. I might have done a frozen transfer. I might have done genetic testing. But all of those things, if you chunk them down, they're so much more surmountable, and you're not going to be demoralized. And when Jess reminded me of the importance of chunking it down, I was able to just see a bit of a glimmer of, Tamara, you nailed the chemo. You did it. You got all the way through. They didn't have to reduce your dose. Yes, the side effects have been like really bad, but you have managed to smile every day. You've managed to get out of bed. You've managed to keep working. You've managed to stay connected to your community. I'll show you something else. Look at this. I've done some artwork. It's not paint by numbers. Something similar. It's diamond art. You probably can't see, but this is all diamond art. So I've done half of that in little bits every single day. So, yeah, just one of those aha moments. The importance of celebrating the fact that I got through the chemo. Yes, there is still a lot of things that I have to do. So maybe the next chunk is just getting through the surgery, waking up on the other side of surgery, however that may look. Maybe the next phase after that will be gearing up for 20 rounds of radiation therapy. But that's going to be something that is chunked down as well. So if you can see some parallels in that, I'm really hoping that has added something to this journey that you guys have gone through or are going through, because it was that moment of, oh yeah, I gotta remember that there are little victories along the way in this journey, and I have to acknowledge them, and I have to, I don't know, maybe not even celebrate them, maybe just go tick box, well done girlfriend, good resilience, good staying power, you got through it, good one. And just, pat myself on the back like Kath does in MasterChef. I don't know if you guys are MasterChef people. I've become a MasterChef fan. Anyway, so thank you to the well dones. I do appreciate it. Fee, look forward to seeing you next week. So I'm on. If there are any Q&A, as I said, I've been a little bit absent for the last couple of weeks. I think I just retreated a little bit. But if you have any questions, thanks, Michelle. Yes, I do. I do need some great suggestions as to turbans. I probably should be careful and not become like a hoarder of turbans, like buy them and then never wear them. I'm hoping actually my hair will start to grow back reasonably soon. Thank you. Yes, please do send me the link for a good one. I really don't like the ones like the babies wear with the big flower. I'd actually just rather wear a beanie. But I just don't think this quite has the professional look that it probably needs. Are there any Q&A questions? You might be furiously typing away. Here's one. Cassie, is there any evidence behind natural killer cells and recurrent miscarriage? Well, there's lots of evidence, Cassie. Whether or not you call it good quality evidence, as you would know, evidence-based medicine is varied. So let me tell you my take on the natural killer cell journey. It is a highly controversial part of recurrent miscarriage or recurrent implantation failure patients. And in saying that, remember, recurrent implantation failure is when we put back good quality embryos and you don't conceive, versus recurrent miscarriage where you have conceived but then the pregnancy doesn't continue. So those two things actually may be completely different as well. So let me talk to you about the current evidence as I see it. So uterine natural killer cells are most abundant in the uterus at the time of implantation. And there are different subpopulations of uterine natural killer cells. I won't go into them, but there is certain subpopulations which we want to see more of compared to the others. You can do a biopsy, and of course that comes with risks of infections, scarring and so on. You can do a biopsy of the endometrium in that window of implantation, knowing the exact number of days of progesterone exposure or days post-ovulation. And you can determine the proportion of the different types of uterine natural killer cells to see if they are normal range or not. There is a school of thinking that you can do a blood test to assess peripheral natural killer cells and that they represent the uterine natural killer cells. However, most practitioners who follow evidence-based practice know that peripheral natural killer cells and uterine natural killer cells, different, not same. So realistically, you need to do that uterine biopsy in a obviously non-transfer cycle. Determine if they're normal, and then if they're not in the normal range, the treatment is prednisolone, and then confirmation that the prednisolone has worked to rejig the population at the time of implantation. So realistically, you're supposed to do a second biopsy. Many people don't do that. And then you've got to believe the research, of which there is no randomized control trial evidence. You've got to believe the research that high-dose prednisolone treatment actually treats uterine natural killer cells to get you the outcome, which is improvement of recurrent implantation failure and or miscarriage. So the current evidence, I think there's no randomized controlled trials looking at recurrent implantation populations. There's trials looking at just general IVF populations, shows no difference. So we have a dearth of information. We have a dearth of randomized control trial evidence in an area that's highly emotive, and there's very little other treatment options. And what happens is a lot of people just treat with prednisolone no matter what. And that is a drug that is not without risk. It's not without risk to increase things like gestational diabetes, birth defects, Cushing's disease, the lot. So do I ascribe to the uterine natural killer cell theory? Not really. Do I indiscriminately give prednisolone without a good reason? No way. Do I look for every other possible cause of recurrent miscarriage and or recurrent implantation failure first? 100%. The biggest problem with the population that we're assessing is that it's just such a small number, right? And so you have to have trials that have large numbers of these populations. So the likelihood that they're ever going to be done is low. And so this is where we sit with the evidence around uterine natural killer cells, is no one's really willing to do the big studies that need to be done. So hopefully that's just enlightened you a little bit more. Vivanya, please could you explain AMH levels a bit? Normal ranges, can they be improved? So the first thing is AMH, anti-Müllerian hormone, is a hormone that is produced by follicles in the ovaries, that's where your eggs are, of a certain size. The size is preantral or antral. So they're not the really small follicles and they're not the big developing follicles. They're the preantral follicles. And what the AMH is correlated with is your egg reserve, how many eggs you've got left in your ovarian reserve. Now, one thing will falsely suppress AMH, and that is the combined oral contraceptive pill. So you need to have been off the pill for 3 months to get an accurate picture of your AMH. That's the only way that you can improve your AMH is by coming off the pill, because the pill will falsely suppress it. There's nothing else that we know of that will improve your AMH, and there is a natural decline of your AMH throughout your life. So, as I have said, age, unfortunately, affects both quality and quantity. So what the AMH is measuring is your quantity. It does not measure your fertility. And that is something that often surprises people who come and see me, is they've gone and done their AMH to assess their fertility, but it doesn't tell them, or me, if they're fertile or not. All it tells me is how many eggs they've got left in their ovarian reserve, which really is an assessment of their reproductive potential. So if I saw a 40-year-old with a low AMH, that's expected. It's expected to be low at 40. If I see a 30-year-old with a low AMH, that is an unexpected, surprising result. That is not something that we expect to find. Often we don't know the reason. Often it's likely that that person has just been born with a lower number in their reserve, and so at every age level as they get older, they sit comparatively less to the average. So normal ranges vary from age to age, and if you have a look at the data, if you get on Google and search AMH graphs, you can actually see the wide range of normative values per age. So hopefully that's a little bit helpful for you. Yes, Cassie, I agree. There is so much stuff out there. I like the Bluetooth. This is actually my daughter's beanie. Mum in the making. Good to see you back. What impact does taking metformin have on implantation? So insulin resistance is in 40% of women with PCOS and in a large percentage of women who have metabolic syndrome, so insulin resistance, high cholesterol, blood pressure, obesity. Insulin resistance is kind of a, what's the word I'm looking for? A measure that we're using it as a surrogate, that's the word, surrogate measure for your metabolic environment. So if you're insulin resistant, that means you're glucose intolerant, which means that your whole sugar metabolic profile is abnormal. And so metformin can help to optimize that metabolic milieu, which is your environment, which is therefore going to improve implantation. There are many aspects of metformin and its role that we don't really understand. It is actually truly a wonder drug, but you've got to make sure you're taking metformin for the right reasons. So if you have implantation failure and you've not been found to be insulin resistant, there isn't really a place for metformin. Metformin I will often use in women with PCOS who are about to go through an IVF cycle, because it will actually reduce their chances of getting OHSS. We know that women who have PCOS have a higher insulin resistance, chance of insulin resistance, but also a chance of ovarian hyperstimulation syndrome. So yeah, it's a tough drug to take. I won't deny. You can get some horrible gut side effects. Here's to the warriors that deal with gut side effects. Totally get where you're feeling. But yes, I do hope it helps for you as well. All right. Oh my goodness. Miss Powell, good to see you. Tibbsy, good to see you. Oh, guys, thank you so much for jumping on. It certainly has been a whirlwind couple of weeks for me, and I have retreated somewhat, but you know what? Getting back on here has been quite good for my soul. Getting back into the swing of things. And I will only go up from here. So from my message at the beginning, remember, in this journey, chunk it down. Celebrate the small wins. If you don't want to celebrate them, then at least do a calf. Give yourself a bit of a pat and say, there, well done. You've achieved one thing in this journey, two things in this journey, partway through this journey, but make sure that you acknowledge yourself for the resilience and the bravery that you have. I'll see you soon.